A warm welcome to everyone joining this session of Gratitude Week, where we are celebrating National Doctors Day for a whole week starting July 1. Now, we continue with our Thanksgiving marathon to thank our healthcare heroes for their untiring efforts and service to the nation during the hard times of a pandemic, and we will carry this gratitude in our hearts forever. Now, this is our Thanksgiving to doctors who have toiled hard for over a year to save us from the COVID 19 pandemic, putting in endless hours and sleepless nights to ensure that patients are cared for and recover from their illness. While we salute the doctors who have been at the front line of the pandemic, we are extremely thankful to doctors who have also been relentlessly caring for patients with chronic diseases like cancer. Because a pandemic doesn't mean that chronic diseases disappear, they still need care, patients need care. Doctors have proactively followed up with their cancer patients to ensure that they have the best care even in the times of a pandemic. Healthcare Global Enterprises, HCG, India's largest provider of cancer care, overhauled its safety measures in its hospitals to ensure that patients receive state of the art cancer care treatment with minimal risk of COVID infection. Using virtual patient visits and Tuesday tumor boards, HCG is using technology to reduce the access gap for cancer patients who got which got exacerbated during the pandemic. The access gap, people are not able to move because of the lockdown. The technology was brought to the rescue by HCG. Today, we have the team of HCG joining us to talk about the challenges of cancer treatment during pandemic. This session is supported by Roche, and we are very helpful. We are very thankful to them for their support. Please welcome the entire HCG team that is joining us now. Dr. B.S. Ajay Kumar, Executive Chairman, Healthcare Global Enterprises, Dr. Bharat Kadri, Regional Director, Gujarat and Rajasthan, HCG Group of Hospitals, Dr. Jayadeep Chakrabarti, HOD, Hematology and Bone Marrow Transplant Unit, HCG Echo Cancer Center, Kolkata, Dr. Vijay Raju Krupesh, Lead Consultant, Intensive Care, HCG Bengaluru, Dr. Vishal Rao, Group Director of Head, Neck and Surgical Oncology and Robotic Surgery and Dean to Research and Academics, HCG Center, Bangalore, and Venkatesan, Vice President Supply Chain Management, HCG Hospital Group, Bangalore, Dr. Indu Ambolkar, Senior Consultant, Medical Oncology, HCG Mumbai, Dr. Mitwa Ghosh, Head of Department of Molecular and Clinical Genomics, HCG. A warm welcome to all of you, and thank you so much for joining us to talk to us about the experience of cancer care during a pandemic. Mr. Ajay Kumar, let me come to you first. What were the challenges that COVID-19 brought for your exclusive cancer care chain of hospitals across India? Because of the pandemic, have you altered your mission and vision of cancer care in India?
Sir, you are on mute.
Dr. Ajay Kumar, would request you to please.
You are on mute. You are on mute, sir.
Yeah. Thank you for having us today, and we appreciate it very much. As you are well aware, Rishad, that pandemic, what happened is probably once in a generation. And when the first wave came in, and obviously we were totally unprepared, cancer being a chronic disease. And one of the things about cancer is a long-term treatment. And time is of essence in managing cancer. So when the COVID happened, the issue was, can the cancer patients get the right treatment at the right time, or are we going to see them come in advanced stages? So in the first wave of COVID, obviously nobody was well prepared. But being a focused cancer group and not really catering in just a general hospital, we really put a lot of efforts to manage the cancer patients and to give them the advice regarding why they should come for treatment, and really try to use the technology to the hilt so that we could really give the advice going to their home through these means like Teams and other means, tumor boards. And that, that is an enormous experience we had. So when we were getting a better recovering and the patients started coming back, and we looked at, India, in one of the things, our hallmark of HCG is that we are pan-India. We are not one single center. So there is a great advantage to the patient because accessibility and affordability is there. They can go to the nearest cancer center and take treatment. My philosophy has always been, when I started HCG, the patient should take treatment, go home and sleep in their own bed and not away. For example, they should be with their loved ones, even if they have cancer, even if they have advanced cancer. So this has been the vision with which we started HCG with the hub and spoke model. So during the pandemic year, what we saw the first wave was a remarkable thing where people who were coming to big cities, patients were treated, were looked at near their home treatment. And HCG actually provided that. Because you take, for example, Nasik or Angol, Vijayawada or Vizag or Ranchi, people didn't have to go to, come to Bangalore, Delhi or Calcutta, but they could go to the near place and take treatment. So there was a shift on patient movement. Actually, our tier 2, tier 3 cities did better than they were before because of the pandemic, because it made the centers accessible and, of course, affordable for them. And second thing was, and this is a sustainable model, we believe in future that will sustain. And second thing, what we saw was the patients who came, for follow-up and all, we started doing through online follow-up. This helped them a lot, better understanding for us, for the doctors. And the other important thing was the doctors' multidisciplinary clinics. For example, if I am talking to a patient, say I require a surgeon's opinion, a medical oncologist's opinion, radiation oncologist, pathologist, or radiologist, I could call them online immediately and give advice. So what used to take actually weeks for us to get together the team, in the pandemic, we were able to do it within a matter of minutes and give this kind of advice to the patient, which was very helpful and appreciated by the patients. And also our doctors really kind of learned this using the online to come up with the solutions. When the second wave came, we were far better prepared. We not only, took care of this by a lot of preparation. I think things have gone very smoothly in the last 3 months. And we can see that the things actually are getting back to normal in spite of second wave, in spite of we treating cancer patients who had COVID. And of course, as you know, in the media, you have seen how people ran out of oxygen, people ran out of beds, ventilators. We managed in HCG, as Dr. Krupesh hopefully will later on talk, how effectively we managed, and our survival rate in cancer patients with COVID was really good. So all of this shows that we learned our lesson first wave. From that, we implemented in the second wave across India. And, we also have multi-speciality hospitals where we treated COVID patients successfully. And all of this, of course, has been a great experience for us. But the most important thing is we are very patient-centric. And I think this episode has made us more patient-centric, understanding the needs of the patient. So going forward, I think this is a game changer, where as doctors, multidisciplinary clinic will focus more and more on the patients, how to even do follow-up at home, what are the reasons they have to come to the hospital, limit the visit to the hospital, but do essential things. So this is how we move forward, and that is the HCG differential in terms of being very patient-centric.
Right. Another question to you, Dr. Jayakumar. HCG hospitals have literally brought cancer care to the doorsteps of people. We have a chain of 15 hospitals in India. But during the pandemic waves, the first wave, the second wave, and it's expected the third, and many and more can come. Did you see a fall in footfalls, in OPD footfalls of newer patients who you may not have followed up early? And do you think that for somebody who suspects that he has cancer, should he step into HCG over any other hospital? Because yours is a specialty care, cancer care hospital, what are the advantages of new patients coming to
Yeah.
HCG. Did you see a drop in footfall?
Yeah, regarding the footfall in the first wave, we did a deep analysis. We found a 20% decrease in the footfall. It is not the patients who have cancer who are on treatment. Obviously, they continue to come. There was disturbance because the public transportation was not there. And of course, we did our best. International patients significantly dropped because the flights were not there. People coming from other parts of India were less. But we went through an enormous experience here. We made alternate arrangements for the patients. So the drop of existing patients who are on treatment was not significant. But having said that, the new patients, for example, if somebody found a lump in the breast or abdominal pain, suspected cancer, obviously because of the COVID, they were afraid to go to hospital. So that got delayed. Because of that delay, we saw a drop of a 20-25% drop in the actual new patients showing up, which now recovered in the first wave, and now in the second wave, they're beginning to recover. So the only concern here is the implications that possibly for a while we will see patients who are coming in more advanced stage compared to coming early. That is the main concern we have as oncology dedicated centers. However, we have done a significant digital media and branding to see that patients with cancer do not fear COVID. The message we have conveyed is, well, you have COVID, I think cancer is obviously worse. You cannot ignore. And coming to an oncology center is somewhat of protects you from COVID because we are not treating that many COVID patients. So with this, we have been, of course, now with the vaccination, it has been a game changer. Now, I think we did see a fall and it is recovered, and we hope in the future patients without fear will start coming very quickly, so that early stage treatment obviously is better. We're obviously waiting for longer makes a change in the approach outcome to the cancer patient. That is how HCG has all along been, talking about creating awareness, why it is so important. Take, for example, breast cancer or oral cancer, head and neck cancer. Early stage is pretty much curative. So it is very, very important not to wait. And hopefully this message will be driven home. And now, at least with the vaccination taking place, people will start coming at an early stage.
Right, definitely. COVID may or may not kill you, but cancer, which is not treated, has a good chance of killing.
I call it a collateral damage. One of the things I said is the collateral damage is what we need to prevent. We can't have collateral damage because of COVID, the fear of COVID. The COVID death may be 1.5%. The cancer mortality is higher. So obviously, we have to focus more on that. While COVID is very immediate, we have to focus on oncology, cancer patients, make sure they do come at the right time. And this is where I think HCG has played a vital role to give that better understanding, less fear. And we have seen that result happening.
Right. Dr. Gadri, how did you manage follow-up of existing cancer patients during the time of the lockdown in Gujarat, Rajasthan? Were treatments deferred? Were surgeries deferred or delayed? What was the follow-up like?
Dr. Bharat, I think. Bharat?
Dr. Gadri, I would request you to please unmute yourself.
Yes. Yeah. Can you repeat? There was some disconnecting.
Yeah. My question is, how did you manage the follow-up of existing cancer patients during the lockdown in Gujarat and in Rajasthan? Because Gujarat was badly affected during the second wave. Was surgeries postponed or treatments put off for some cancer patients?
So yes, initial period when the lockdown happened during the April-May, there were multiple issues. People were not allowed to come from the other states. We had a lot of patients coming from, say, Rajasthan or Madhya Pradesh. So we talked to the concerned police commissioner, stating that these patients will come, and if they show the letter, we used to send them a digital letter which they used to show at the border. That's how they were allowed. And we were initially, there were a lot of issues in terms of our own staff being stopped at various places for going to the hospital. But gradually, we had to represent to the state government saying that the cancer patients cannot wait, cancer treatment cannot wait, and it has to be continued, which the government agreed upon. And that's how we ensured that the follow-ups happened. We did the surgeries also on a regular basis. Gujarat, there were specific issues related to testing. They were not allowing RT-PCR for the patients because the kits were limited, and the government also wanted the numbers to be low. So there are multiple reasons, and they were not allowing. So we had to represent them and tell them that any surgery that we do, if we do it without the RT-PCR, it can create problems for almost 15-20 people who are present in the OT. So that's how we managed. In Gujarat and Rajasthan, we have 3 multi-specialty hospitals also, which, by the way, HCG was the first private hospital in the state of Gujarat to take up COVID patients in the private sector. And we ensured that for 2 days, we made strong protocols in terms of the clinical protocols, and administratively also we ensured that how the staff is going to take care of themselves, because we were to treat both COVID and non-COVID in the same building. Very few hospitals have done this. In the same building, only the entry and exit were separated out. So we were able to do that, and with the strong clinical protocols in place, the outcomes were much better.
All right. Let me head over to Kolkata now. Dr. Chakrabarti, I want to know from you, are blood cancer patients more susceptible to contracting cancer than, say, solid cancer patients? Did any of your patients contract COVID? How did you manage the treatment? Because I don't think you would treat COVID patients at your hospital.
So, thank you. First of all, thank you for getting me into this. Thank you, Chairman, sir. Thank you, everybody. As per to your question, I feel that, or it's a fact that patients with hematological cancers definitely have a much lower immunity compared to solid organs, or anybody who is having chemotherapy rather for hematological cancers would definitely be much more prone to the effects of any infection, and COVID being one of that. I'll give you a couple of examples. A patient who had a bone marrow transplant around 2 years ago had COVID infection last year. And even now, when we test him, he is still COVID positive. So, but that's still good because he's alive, he's surviving. We treated him. So that is good. Whereas another boy whom we transplanted, let's say 6 months ago, couldn't make it when he had COVID. So, patients do succumb to this kind of infection, and the less the immunity is, the worse the outcomes. So, anybody who has got a hematological disorder, especially a malignant hematological disorder, has to be very, very careful.
How do you manage them? How do you treat your patients then?
So, as Chairman Sir was saying, that the first phase was hard, was difficult, and we were learning in the first phase. And I remember, last year we were so desperate. Patients were far away. They have a relapsed leukemia, let's say. They were not able to come. And I wrote Chairman Sir an email, expressing my despair, a very long email, which he read and acknowledged last year. But that was one of the difficulties, that we didn't know how COVID is going to spread, how severe it is going to be, and whom it is going to affect. But as we went along, many of us sat together all around the world, and we have all come out with certain guidelines and certain observations. But more importantly, common sense is needed. So, for example, when we did, when we were transplanting patients last year, we made sure, as our colleague from Gujarat said, that we were making sure of the segregation. So not only the establishment or your air quality has to be separate, but the services. So a person who is who is in the COVID ward, do you really want that person inside a bone marrow transplant unit? Maybe not. So your services, it has to be segregated. And thankfully, we were able to manage that, with guidance from our seniors, from Chairman Sir, from everybody. we were able to do that last year, and we did manage to do almost 20 transplants last year, even during the COVID period. So definitely segregation was one of the things which helped us. The other thing that we look into is that how to make the treatment less immunotoxic, or not decrease the immunity too much, and in spite of that give a very good effect. So I think all of us, hematologist or oncologist, or in fact every doctor who are treating such diseases, had to go back to the blackboard and find out, that now you've got a disease. For example, we used to add a drug called rituximab in lymphomas. But now if I add rituximab, my immunity goes down even further. So we had to take a step back and then realize, or think about what we are doing, and try to come out with treatment protocols which will be less toxic to the patient, in spite of that being very effective.
All right. Dr. Rupesh, you take care of the intensive care unit in HCG Bangalore, and I think you were treating COVID patients there. So, how did you triage and treat these patients? Because you have patients, cancer patients who don't have COVID, and you have cancer patients who have COVID. Both need additional care. So, how did you triage and treat them?
Yeah, good evening, all, and thanks for me getting in here again. See, for us in Bangalore, the main advantage is the infrastructure itself was like made to treat such patients. Like in Bangalore, we have different towers which has a different entry and exit points. So it was very easy for us to identify, okay, where is that we are going to treat the COVID positive patients. So we identified the tower, and the chairman called me and told me, "Are you ready to take up?" I just told, "Yes, sir." How much time do you want? He told, "Give me 24 hours. We are in." Then he asked me again, "Are you sure that in 24 hours we can do it?" I told, "Infrastructure wise, we are there. Only thing is we have to work out some logistics, and everything was placed within 24 hours." So we had the advantage at KR Bangalore is we have two ICUs. Already we had a post-operative ICU, which is around 18 beds. We had isolation, which is around 5 beds. We had medical ICU, which is with individual rooms with 7 beds. So all we had to make was we have to switch in the ICUs. So we made medical ICU into surgical ICU. The bigger surgical ICU we converted into COVID ICU. We took it the isolation also. So now the left out part was staffing. Staffing, actually, if you see the planning to treat patients, whether it is COVID positive or during this pandemic, it was meticulously planned from first almost a year from the first wave itself. Because immediately after the first wave, as soon as the vaccine was available, management and all of the staff were on the vaccination drive. We thought that yes, we are going to vaccinate our nursing staff, and whether it is MSWs, whether it is IMRs, ward boys, everything. We saw to it that within 60 days time, almost our vaccination was 100%. So this time, regarding the staffing, it was not much a problem. So only thing is segregating the patients. So the tower, which was marked for COVID ICU, had a separate entry and exit. So all patients who were suspected COVID or COVID positive were taken in that tower. Rest of the cancer patients were admitted in a different tower with all the facilities as normal as it was. If anybody just walks into the ICU, they just doesn't know this hospital is catering for COVID positive patients. The scene was like that.
Right. But Dr. Rupesh, then for anybody coming to your hospital, an RT-PCR test was mandatory?
Actually, during the pandemic, it was not mandatory. We had our own patients. There are we had to cater 3 types of patients. See, patients who are already on our treatment roll, new patients who are coming down, and patients who are enrolled recently and they are waiting for the surgery. So during pandemic, you never know. Patients may be carrying subclinical infections. So we made it mandatory that all patients who come for surgery will have a RT-PCR, but it was done at their home. So second thing is any suspected patients like SARI-like symptoms, severe respiratory infections, they were admitted in isolation. They were tested with RT-PCR. If they were positive, they used to come to COVID zone. If they were negative, they used to go to the normal ward or the ICUs. So RT-PCR was mandatory.
So it's a well-defined process on how to treat COVID cancer patients and non-COVID cancer patients. Dr. Indu, your center is in Mumbai, and in Mumbai, we have seen a huge influx of COVID patients during the second wave. Uh, were any of your care patients affected by COVID? How did you manage them? What happened to your existing cancer care patients in Mumbai during the second wave?
So, thank you, sir, and thank you for inviting me. So, basically, we had planned meticulously to manage our patients because ours was non-COVID hospital. So, we had planned the policies, we laid down the policies. First of all, we made the COVID committee in the very beginning. So the COVID committee consisted of the intensivist physician, all the oncologists, our infection control nurse, and the medical administration. We formulated the policies. How are we going to deal with such patients? Because we had to manage not only the active cancer patients but the new cancer cases also. At the same time, we wanted to protect our employees also. So we had appointed one resident doctor in the emergency department, and that doctor would screen the patient at the entry of the hospital itself. So if the patient is having some symptom related to COVID, like suspected COVID, then this patient would be sent to COVID dedicated hospital. And if the patient is already taking treatment on active treatment, this patient will be advised to do the RT-PCR test. So every single patient who was on active treatment had advised the RT-PCR test. And once the test report comes, if the patient is not symptomatic, we would continue the treatment in the hospital. At the same time, because cancer treatment is a long treatment, especially the chemotherapy, radiation, it goes on for weeks and months. So we would advise RT-PCR test every 2 weeks. Now, apart from that, we have seen a very different kind of effect, that our surgeries had increased tremendously. We have seen that there is increase in the number of surgeries from September onwards, and those number of surgeries we had started seeing because ours was non-COVID hospital, and we were getting patients operated by the doctors on panel. They were bringing their own patients because the patients were feeling safe in this hospital. At the same time, the doctors were also, like the surgeons, were feeling very safe to operate on such patients. About the employees, I would like to tell you that our organization has provided the PPE kits and masks to every single employee, including the housekeeping people also, the nurses, the front office, the doctors, every single person. And at the same time, we have taken care of our nurses by providing them the high protein diet. So right. We have taken these measures, and our COVID positivity rate for employees is very less.
What about the patients, Dr. Indu? How many of the patients
so we have
cancer?
Seen, including OPD and yes. Yeah, I'm coming to that. So we have seen more than 18,000 patients from March 20 to June 21. Out of these patients, we have seen 91 patients were COVID positive, and out of 239 employees, about 39 employees were positive, but only 2 employees got hospitalized. and they did not require any oxygen support, they just required the steroids. So almost all the employees recovered, and all of them have come back to work. And so far we have vaccinated around 91% of all the employees. So and I want to tell you that even after the second wave, even after the vaccination, we are still following the COVID appropriate behavior. We are still using the PP kits and 95 masks, and we are still taking care of our nurses by providing the high protein diet.
Could you repeat, Dr. Indu, as a percentage of total number of patients seen, how many had COVID?
Total number of patients, total number of how many patients were COVID positive?
Yes, as a percentage, because the amount you mentioned was very little.
Yes, it was very little, actually 0.2%.
So that's great. It goes to show that the management of your patients was so good that they got their treatment and they stayed safe from COVID.
Absolutely,
Right.
absolutely, yes.
Mr. Venkateshan, I want to come to you next because, what I'm hearing from your teammates is that everything was planned very well to prepare for whatever happens. But all over the country, we have seen hospitals swamped because of COVID patients coming in. Yours is a specialized cancer care hospital, but did you face any shortage of equipment, drugs, oxygen, any of that during the lockdown?
Yeah, hi Anisha. Good evening. Good evening, everyone. So this was a first time. It was a experience for all of us. So before the wave one, we have planned well, and we got some COVID consumables and all in the COVID wave one. The difficulty was in COVID one was the transportation was very difficult. Like that time, they have blocked all the transportation, like air, train, all this. So we had a very difficult time in the transportation. So we sent all the goods, consumables, drugs, everything by road from Bangalore to Cuttack, Bangalore to Ranchi. So the first wave was very difficult to manage the supply chain actually. And second wave we were very well planned, and we were ready for that. We planned and we got all the consumables, everything in rack. So there was no much crisis. But obviously there was some sort of drugs like your Actamira, like omalizumab, all these consumables and other drugs which is blocked. That was a very difficult. Dr. Vishal Rao knows that amphotericin B was a big shortage after post-COVID, this mucormycosis. So that all have been taken care by drug controller. So we are not freely, we are not able to buy from the vendors. It was controlled by the drug controller. So still we were very much able to manage the patients with the support of our clinician team. So really we would like to thank our clinical team. They have predicted well, they have given the requirement on time. So we have managed and arranged all the drugs and consumables without any difficulties. And yeah, there were some small hiccups like delay in the supplies, but somehow we have managed well. And really we would like to thank all the clinician team for this great support to make this patient happy, and the hospital operation was smooth. So
Right.
Yeah, we managed very well. Yeah.
Dr. Ajay Kumar, what are the operational and clinical learnings from the pandemic?
I think the important thing from the operation was when unexpected things happen, it is always like an emergency. For us, we never anticipated that there will be shortage of oxygen and shortage of drugs for the patients who need. I remember vividly a day when our Dr. Vishal Rao, hopefully he will talk in the next few minutes. He gave a statement that HCG is going to run out of oxygen in 9 hours. So, it was very scary because we had oxygen supply. We had 18 people on the ventilator, 24 people requiring oxygen. And what do we do if we run out of oxygen? And we were hearing stories of hospitals where people ran out of oxygen and patients died. And it was, like I remember at 1:30 in the night calling the oxygen suppliers saying, what are we going to do? And he said, look, I just filled in for government request for a government hospital. I can't do anything for you. So we were running pillar to post that night, all night, and trying to get, fortunately, we managed. Not a single patient was deprived of oxygen in our entire system. Thanks to the ability of our logistics people, the doctors, Dr. Krupesh, Dr. Vishal Rao, all of them got involved. See, the key was, the learning here is it's a team effort. When we talk about a patient, each individual patient, I'll just give you one dramatic example of a patient. A patient, a CEO of a big company, arrested in a multi-speciality hospital. There were no beds. The chairman of another hospital, another group called me and said, can you help my friend, a patient? So we didn't have any beds. Krupesh said, we don't have any beds. I said, Krupesh, we have to make a bed. So we went out of the way. We got a bed in, and we got a ventilator from the OT operating room, made an extraordinary effort, and the patient survived. Went out of the hospital. They were very grateful, the family. All I can say is, extraordinary times require extraordinary effort. And when you do extraordinary, that is the hallmark of HCG. What is considered not possible, we should make it possible. And whether a patient from cancer comes to us and says, look, I've been told I'm terminal, nothing can be done, why can't we do something? That is where our Tuesday clinic was yesterday, morning to morning. That is what we spent 2 hours on. How can we make it possible? See, when you really put your time and effort to any situation, whether it is pandemic, whether it is cancer, advanced cancer, is almost like a pandemic every day for cancer oncologists who are dealing with very difficult diseases, and the patient, family, the financial issues. How am I going to make this treatment is great, but no, I cannot afford. How do you bridge the gap? HCG is specialized in bridging the gap. No patient should be turned away. Can we do that? So we have learned a lot from pandemic. HCG is learning. And future, I think, going forward, this will be for the benefit of patients and society as large. And what we have to come out, I always say is, we have to do research. We have to do our own. We cannot be copycats. We cannot say, let somebody else do, we do. We need to learn from our own mistakes. We cannot let others say, let them make a mistake and do. So I think going forward, this entire pandemic, India has done very well. Second wave also we handled very well. We had our own vaccination. We should start being proud of ourselves. We should start becoming in the front line like our doctors did. Front line for not only COVID, for a front line for all research. Publish, do, challenge the world. And that, I think that is the great string of giving us that, confidence that we can handle anything. That is what we need today. And this COVID situation, pandemic, has provided this opportunity for us to scale up to that level.
Definitely, Dr. Jayakumar, this is why we are doing this Gratitude Week, to say thank you to doctors who are doing everything and more to take care of the patients.
And Anisha, I just want to say something. I am in US. The media always talks about negative things about a country. When people were running pillar to post for oxygen, huge news on CNN, New York Times, people dying and all. But what about the good things we have done? Nobody talks about it. Enormous. You look at our doctors, they got exposed. Nurses, they got exposed. They had COVID. They still, we managed them. They still came back to work. And, the fear was not there. And these are the heroes, frontline people. And, nobody talks about it. I call it unsung heroes, honestly. But anyway,
we are talking about it. We are talking about this. And we hope that everybody in the media will continue doing this, because without our doctors, we'll be nowhere. Now, Dr. Vishal Rao is also with us. Dr. Rao, sir has already spoken about how technology is being used in HCG. Could you elaborate a little on this, how technology is impacting healthcare now in this post-pandemic world?
So I think, the COVID pandemic created definitely a watershed line for technology. We were the people who actually were running away from technology, and I would say the medical fraternity for sure. And we were the ones who got glued to it during this pandemic. I think the most important things for us during the pandemic was accepting the online way to reach out to patients and assist them. And I think what I allude to is one such thing that my resident came to me. One of my senior fellows came to me and said, "Sir, during this pandemic, we need to reach out to our patients proactively because we were looking at how the pandemic was unfolding." I still remember she did a very nice structured approach of a 3-tier protocol using mobile health. So I used to talk in some of those talks to them about how to use mobile health. mHealth is a program of the WHO, and she said, "I have had some thoughts on this, and I think I can do this." I told her, "Go ahead and try it," and she did something so beautiful out of it. She created a 3-tier protocol wherein she actually reached out to hundreds of patients. And what she did was, in the first part of the questionnaire, she did telephone calls to each one of them. And the team had a rehabilitation team, had a nurse, our oncology nurse, and a doctor. They did personal phone calls to each patient, and they created a 10-point questionnaire. At the end of the questionnaire, they created a scoring system. That is, if the scoring system was below 2, this patient needed rehabilitation services. If the patient was between 2 to 6, then the patient needed, in addition to rehabilitation services, a video consultation. And beyond that, if it was 6 to 10, then the patient needed a personal attention with a... Now, with this 3-tier protocol, the first one she did after the phone call, she connected them with the rehabilitation team. And thereafter, after the rehabilitation team, which had 9 members, psycho-oncology, the psychiatry, the yoga experts, the dietitian, the pain management experts, the nutritionist, the physiotherapist, the dentist, the speech and swallow team. Now, 9 of these teams would sit together to actually talk to the patient to say, "How are you all doing? Are you eating well? Are you in a mental frame of mind? How is your mobility?" Now, this is the kind of attention they gave. And thereafter, you see that they ensured that at the last tier, if in case we needed a personal visit, where do they go? Some people were from some Gram Panchayat. We ensured that we reached out to our doctors network in Hubli or in the peripheries, and that's the hub and spoke model the HEG stands for, where you have spokes across the state or the country where you're able to go to the last mile. We reached out to them. They reached out to a general physician in that area and said that you can go and visit him and maybe we can connect through a video consult and guide them. That is what technology bridged to us to serve at this juncture. And I believe this was a very, very important step of learning for us, that while we have high-end technologies at HCG like robotics, we have the precision oncosurgery, we do high-end cyber knife, all sort of, we were able to create a ground shot for technology, something to reach the common man during this pandemic, where we are able to touch lives through simple methods. And we had a very interesting learning of reverse mentorship. A student was teaching me how to use technology. I'm not that I'm technology crippled, but she was able to teach me how to use mHealth in an effective way. And for me, it was a good learning because my fellow is teaching me how to use technology. So that was a very, very big step for our learning on how could we evolve into more amount of online health. HCG created something called Comment. Now we have something called CMEs, Continued Medical Education. We created something called Continued Online Medical Education, Comment. And as the head of academics, I remember I was kind of quite skeptical on how many people would attend it. We had not more than 100, 200 people attending each session throughout the country, sometimes abroad. So we really learned to re-question what we believed in. We did courses on laser surgeries, on robotic surgeries during the pandemic with no attendance on virtual mode. We worked with experts like Microsoft to look at teleportation, HoloLens. I mean, it was an extreme use of technology to create a ground shot connect. And for me, that was the greatest learning. And I think I would like...
continue with this, Dr. Rao? Would you continue with these new things you've learned? Do you think they are more efficient? They can be kept even in post-pandemic. If things turn to normal, would you continue to use all this?
See, I think COVID has created a watershed line for us to work in a new way. I'm recollecting a very beautiful report by Boston Consulting Group. They wrote a very beautiful report on post-pandemic changing the way of life through hands, heads, and hearts. It actually talked about how the world is going to change, because I think we've learned a new way of work-life balance. we've learned a new way to balance technology and at the same time remain productive during these most unproductive times. And this is the
Right.
most beautiful aspect of being productive. And again, I
Right.
think the special aspect of gratitude, because this is the gratitude week, and I am thankful for IHW for all the efforts you all are taking. For us, this gratitude was also about taking this gratitude to the lowest level of not just doctors, but even the nurses, the administrators, even the housekeeping staff, who actually were able to embrace all of this technology, connect with each other, and actually share this entire work burden at this juncture. And
Dr. Rao, I wanted to ask you, sorry for interrupting you, since you're the head of the academics. Now, has your experience in cancer treatment and understanding of cancer by any way helped the country to understand the behavior of coronavirus in the body? Because severe cases are caused by our own body's immune dysregulation. Has a genome lab taught us something new about how to, proceed with this pandemic?
So, there are a couple of points here that I would like to mention. I think first thing was during the pandemic, the first, I remember in June 2020, I called up Dr. Ajay Kumar and I told him, I said, sir, I think we should start the plasma bank. And he was asking me, he said, really, do you think this? I said that this is definitely going to be required. He said, if you think so, go ahead and start it. We created the first plasma bank for the country at that time. Now, at that juncture, I must tell you, see, I wrote an op-ed called the Pandemic CEO. I said the true CEO of an institute is a person who stands with leadership from behind. He stood behind us. And I'll tell you, we must have tortured his life out, troubling him on weird times, asking him all the most strange questions, questioning status quo, questioning his own decisions, and he accommodated our madness. And every time our company would say, what are you next up to? And I would say, no, sir, I think you please believe in us. This is something that is needed for the people today. So we set up the plasma bank. We did 7 clinical trials during this time. And he said, do you think we have major? And we have a very good immunology lab called ICREST at HCG, where we do a lot of immunology work. We are friends with viruses. Oncologists are friends with viruses because viruses cause cancer. So it's not that, we are far away from virus. So we just thought, can we take a detour? And he encouraged us. He just told us, yes, I think it's worthwhile time to take the detour. So the entire immunology lab was actually working on looking at, can we work on COVID-related immunological treatments. We actually published more than 25 papers during this time, which was relevant to COVID because of our understanding of virology. Mm-hmm. Just going beyond the understanding of thinking that this is a silo that only oncology should do oncology. This virus was for the world. This was a pandemic that had to be solved by every responsible medical fraternity person to participate. This was not the time where you shut down your institute, sit at home and say, I'm working from home. That's what I asked organizations, that you come out at this time and show your talent and say that this is what I can contribute to science. And we did that. We did 30 papers, we did 7 research. We worked with DRDO to create the chest X-ray screening. We did interferon therapies, we did plasma banks. We did genomic surveillances for the viruses to scan the viruses. So I think across the span, we put our full effort to actually see what we could do to contribute to the pandemic and make a small mark from HCG's side as a contribution that when you look back in the decade, we said we did our part.
That's great. That's awesome, Dr. Rao. Dr. Ghosh is also with us. She, of course, is in charge of the lab. So, Dr. Mitwa Ghosh, could you talk to us about the lab? Was it affected? Was its operations affected because of lockdown, etc.? And are you involved in the genomic sequencing of the new COVID mutations that are coming up?
Yeah, hi. Good evening, and thank you for inviting me to this forum. So, as you know, the labs, a diagnostic lab is an important infrastructure and the supporting system for the hospital. So, while our doctors were busy treating cancer patients and COVID patients, the lab did not, they were very proactive. They were more proactive, and we tried to work on different things. We tried to see that no tests are stopped or reports are generated in time. Actually, reports are generated before time rather, so that it helps the doctors to take the right treatment, to decide on the right treatment for the cancer patient and the COVID patients. So it has actually not affected the lab at all. We were very proactive and productive during this time, maintaining all the COVID protocols and all. Yes, there were some team members who were exposed to COVID. So when they fell sick, the other team members came to the bench and did all the work in time so that nothing is stopped. And we also gave our time in new development, innovations, etc. And as Dr. Vishal Rao said, we quickly developed an RT-PCR lab so that we can help the patients with the RT-PCR test. And this was done very secluded from the cancer lab so that no samples are contaminated or no samples are affected. Currently, we are also involved into this genomic surveillance, and yes, the lab is doing the genomic sequencing of COVID patients to find out new variants and all. And the other thing which we did was we strengthened our logistics. So no patient had to come to the lab to give sample actually. The logistics team went to their home, got samples, got their reports over email. We did telegenetic counseling for them. So, and we worked with the clinicians very closely on the digital forum so that they can provide the consultation along with the lab. So these are the proactiveness, or these are the steps in the lab. And I think we have learned a lot. Anisha, we have learned a lot from this, how to take up challenges in this challenging time.
Definitely. Dr. Ajit, you spoke about your hub and spoke model, and you said that you don't want to turn cancer patients away because you want to treat as many patients as you can. But in our country, cancer is still seen as a rich man's disease, a Western disease. Very basic cancer care is chemotherapy, etc., or drastic surgeries are done in government hospitals, but there's a long waiting line. And for most people, cancer treatment just gets them near to poverty. Will bereft them of all their wealth, all their assets, because the treatment is so expensive. Could you talk about the financing model that you have, and how do you improve the access to cancer care in our country?
Yeah, this has been one of the great challenge for us. How do you create a model? This was the Harvard study also, like Harvard called as the Robin Hood model, essentially cross-subsidy model. So one of the things we look at is, rich or poor, cancer doesn't know it's rich or poor. The cancer only knows how to attack, how I can win the war over them. That is, so our model is to see how we can win the war over cancer. Rich or poor. So the whole thing is cancer, like I always tell in my tumor boards to my doctors, colleagues, even in publications, cancer can be treated only one way, right way the first time. See, for example, if you look at the era of cobalt therapy, for a long time we said India is poor, we'll do cobalt. HCG took the initiative and we challenged the system. Doesn't matter, we should bring in linear accelerator. That's the right treatment. Because the cobalt was so inferior, it not only did not give the result of cancer, it also caused damage to the normal tissue. And for decades, we were treating it, saying that we are a poor country. Canadian government made cobalt only for us, but no Canadian got treated by it. So I took it as a challenge and challenged on the various forums to say we need linear accelerator across India. And we set the trend. We were the trailblazers for that. Now, of course, cobalt has literally been phased out of India in the last 10, 12 years. So we like that we should go step by step. For example, when you see a patient who requires surgery, right now we have done, Dr. Pramod is doing a surgery on a major patient, a girl who cannot afford. So we go through crowdfunding, raise funds, HCG Foundation. Each individual, like we talk about cancer care personalized, it has to be personalized. It cannot be one answer for all. We have to take up the challenge. Our doctors, our doctors who are here, take up the challenge. They say, can we raise funds? I remember one of the doctors going through the Motorcycle Association and raising funds. So there are various ways we can do, and HCG Foundation itself helps. So there are various ways to skin the cat. They say, it is possible. I feel nobody deserves to be refused treatment because of the cost. In fact, in my tumor board, if somebody says, I couldn't do the treatment because of the cost, I take them to task. Let us find a way to treat, because when the cancer recurs, the cost is much more enormous. When the cancer recurs, the suffering is more enormous. us. Sometimes I feel it is better not to give inferior treatment, no treatment at all, rather than give inferior treatment. So we cannot afford to give inferior organ preservation. Imagine the plight of a woman who has sacrificed the breast unnecessarily. How does her family treat her? How does her husband treat her? What are the social issues? We have gone into the depth of it. We interviewed nearly 250 women who had underwent mastectomy and found out 75% of them face issues with their spouses because they lost their breast. So there are so many issues here, and here we are not addressing. We simply go and say, okay, let us do a mastectomy. It's easy to do a mastectomy. It's easy to do a mastectomy. Very difficult to preserve the breast. And we have Dr. Mahesh with us, who is an expert on that. You know, when you see his surgery, we don't even see a scar. Scarless surgeries. So we need to evolve with all this so that we can stop using the terminology like cancer victim, cancer survivors, palliative care. These are deadening words to the patient. We should stop and actually tell the patient, you have cancer which has gone to this part of the, this is how I will treat, and this is how I will. Look at lung cancer today. With metastasis in the liver or bone, they are living for 7 to 8 years. Breast cancer patients, even with meds, in my own practice, even in US, even in India, today they live for 10 years with bone disease. And what about this stage? You know, how can a patient with one disease in the one lesion in the bone and multiple lesions in the liver can be the same stage 4? What happens to the patient when you tell them you're stage 4? Oh my God, I'm gone. I'm already on my way to heaven or hell. That is wrong. We have to use right terminology at the right time. As doctors, I really take the doctors to task for this. Various conferences, everywhere, palliative care, they start. We have to stop using, because this is arcane, this is old way of treating. Old way of, because at that time cancer did not have treatments. Every 75 days today, cancer treatment is changing. People are living longer with good quality of life, with no organ, sacrificing organs. So we need to come to the modern era and push and do more research. So more things. For example, we need to do more research for our own Indian patients. In head and neck cancer, we have found there are mutations which have never been reported in other ethnicity. So in that case, why are we not doing more research? Why are we following the West? What is good for Caucasian may not be good for India. There is so many things we are doors to knock on and learn. So it is an enigma. Cancer is an enigma. No, I know in 45 years, I can tell you one thing, last statement. If somebody asks me, are you an expert in cancer? I say, no, I am not. Every day I'm learning. So we are learning. Nobody can be an expert in cancer. That is why HCG's way of approach, team approach is very important. Okay, so this is a task, and we will on the way, but I don't know whether we'll win the war on cancer, but certainly we will manage cancer.
So, Dr. Shikumar, very briefly, we've come to the end of this discussion. You've given us a lot of high points of how cancer care is being done in our country, is being done in HCG. Now, how do you think it evolves? How does cancer care evolve from here on in the future? If this pandemic becomes endemic, if COVID stays around, which many people are expecting, it become less lethal, it just stay around for a few years longer, does it change cancer care? How do you evolve?
I think with this pandemic becomes an endemic, I think there is a lot of information on vaccination. We do believe vaccination, and is the answer, it may be double vaccination. There are a lot of reports that mRNA vaccination with the regular vaccination may be the way forward. So I think we will, of course, address this issue. But regarding the cancer care as it evolves, I think with this kind of pandemic, healthcare issue has become very important for the government. I think what was lacking, spending only 1.5% of GDP for healthcare, is total disaster. We need to spend, how can a country become an advanced country? Health and education, you have to spend. You can't spend when, for example, we spend for health in India $83. United States spends $9,400. Europe spends $5,000. China even spends $500, $600. So we are way behind. We cannot say, give me the same outcome as what I get in US compared to India and spend $83. So it cannot be cheap medicine. It cannot be, everything cannot. So we have to bring in universal healthcare. We have to really limitless. So universal healthcare is what we are propagating. By bringing such healthcare, the financial issues can be taken care of. So when a doctor takes out a pen and writes the prescription, he is not worried about the finances. That is how we have to evolve for actual proper treatment. All these Ayushman schemes and all are not going to work, Anisha. It is not going to work. We have to develop a universal healthcare, cross-subsidy. Rich, poor have to pay based on their income. Create this fund, CAPEX fund, which will make sure every cancer patient is treated the right way. Advanced treatment is given to them irrespective of their economic status because the insurance will cover for that. That only, for example, I'm a Medicare recipient in US. I can go to any hospital, even though I'm not a US citizen, and get free treatment. No cost bars. That is how we have to evolve. And India is very capable of doing it. If only we put our minds to it and spend the necessary amount for this kind of thing. I have various things I can talk about where all the misuse of funds is happening. I think we need to, health education is the key for us to become an advanced country. If you want to become an advanced country, we have to take care of our people.
Definitely. Thank you so much, Dr. Ajay Kumar, Dr. Kapati, Dr. Indu, Dr. Ghosh, Mr. Venkatesh, Dr. Gadzi, Dr. Pupesh, Dr. Rao. Thank you all for joining us today and sharing with us the work being done by HCG in cancer care in our country now in the midst of a pandemic. We hope and pray this pandemic will get over soon and the cancer care in our country will only get better. And more patients will be treated because a lot of people feel this cancer is the next epidemic in our country. Given the growing population, incidence is going to rise and we need great care and management. We want to thank all of you for doing such a great job for taking care of the patients in such difficult times. Thank you all for joining us.
Thank you, Anisha, for doing a wonderful job, by the way. Thank you. You did a great job. Thank you.
Big thank you to all of you for joining us. And with that, we will wrap up today's proceedings of the Gratitude Week. We still have more coming up. We still want to keep thanking our doctors, our frontline warriors for keeping us safe, for moving heavens and earth to ensure that patients are taken care of. A big thank you to all our doctors. No matter how much we say thank you, it's going to be less. But we'll wrap up the proceedings for the day today. Do join us again tomorrow. Till then, goodbye.